Hello, my name is Jeff Taylor, and we are here in Seattle at the 22nd CROI, the Conference on Retroviruses and Opportunistic Infections. And today I am talking with the principal investigators from the AIDS Malignancy Consortium, which does HIV and malignancy research. I'll introduce them from left to right. Dr. Mitsuyasu from UCLA is chair of the group. Dr. Margaret Borok from Zimbabwe heads the site in Harare. Dr. Tim Wilkin is a member of the HPV working group and is based at Cornell in New York. And Dr. Susan Krown is a member of the KS working group. And which site are you affiliated with these days?
I'm actually the vice chair for international activities for the AMC.
So, global.
She's freelance.
And thank you all for joining us today. We really appreciate this opportunity to talk about what's happening in HIV malignancies. So I'll just let you kind of talk about what you thought was of particular interest at this conference and what your group is doing in AIDS malignancies these days.
You're starting with me?
Yeah, if you'd like to start.
Okay. Well, actually, I think that there were a couple of very interesting papers today on Kaposi Sarcoma. There was a lovely presentation on a drug called pomalidomide, which is a derivative of thalidomide that, at least in an initial study, seemed to show some very high level of activity in people with KS, who most of whom had had extensive prior treatment. There was also a very nice again, preliminary analysis, but I think potentially very interesting of patients in Uganda that can probably help in the future in deciding which patients in Africa with KS may benefit from antiretroviral therapy alone and which patients may need additional therapy.
Yeah, because KS is really a huge problem in Africa. We don't see it much here, but we kind of forget that it's still an ongoing problem that merits a lot of research.
Right. And you know, the AMC is working with the AIDS Clinical Trials Group, primarily in Africa, but also to a lesser extent in South America, doing fairly large randomized trials for treatment of patients with Kaposi Sarcoma.
And in the HPV world, Dr. Wilkin.
Yeah, I mean, there are sort of two areas that were where there were papers presented. One was on cervical cancer screening and other papers on anal cancer screening. So for cervical cancer screening, Cindy Fernhaber, who's an investigator at our AMC site in Johannesburg, presented a follow-up study from really a tremendous study that she presented, or she's published already, that looked at 3 screening tests for cervical cancer, and she presented the 1-year follow-up. I think notably the women without disease at baseline who had low-grade disease, 10% of them developed high-grade disease within a year. So it suggests that we need to monitor the women closely, that a single assessment is probably not sufficient for them, and it kind of shows that we maybe need to have some new strategies to really decrease the risk of cervical cancer. Another analysis showed that HPV testing as a screen for cervical cancer would be a pretty cost-effective. And I think that all of this is supportive for studies we have planned in the AIDS Malignancy Consortium to look at an HPV test and treat strategy for cervical cancer screening. And I did forget the poster I had for the AIDS Clinical Trials Group, where we did a HPV test and treat study. We found a lot of the women, 1 in 6 women, had really extensive cervical lesions that really weren't well treated by cryotherapy. So it has a lot of programmatic implications for sites that are doing test and treat. They really need to have other therapies available besides cryotherapy to kind of do optimal treatment. And then the second broad area was anal cancer and anal cancer screening. There was a big study from Mount Sinai that looked over years of their anal cancer patients over I think about 20 years. And what they found, interestingly, was that HIV-infected people actually had similar outcomes, if not slightly better than the HIV-uninfected people. And they hypothesized that this was because they're doing screening and able to find cancers at earlier stage, perhaps in HIV-infected people.
So that HIV-positive people are getting more intensive care and
yeah, probably their cancers are found a little bit earlier, and that might explain why they had the outcomes that were observed. There was also a study, again from Mount Sinai, presented today, that looked at anal cancer precursors, so high-grade lesions in HIV-infected women, and they found a pretty high percentage, about 25 to 30% of women had these high-grade lesions. And moreover, they showed that the current approach for anal cancer screening in women, which is to use sort of a risk-based to look at their history. Do they have receptive anal sex? Do they have other HPV disease? And they found that really there's a fair amount of disease in women that didn't have those risk factors. So what I took away from it is that really all HIV-infected women could be offered screening for anal cancer. And so, yeah, those are the highlights that were presented here.
Great, thank you.
But I think, Tim, it's fair to say that we don't know yet whether treatment of HSIL is going to prevent invasive anal cancer. So I think that's a sort of good segue into the anchor study.
Yes, I agree completely. We think it does, and a lot of us that do that screening HRA and all the treatments, we think we're preventing cancer, but we don't actually know that. So the anchor study is a tremendous effort funded by the National Cancer Institute, done through the AIDS Malignancy Consortium, as well as some new sites that are just going to participate in anchor. That's really asking the question, does treating these high-grade lesions, does that actually prevent anal cancer? So the study is enrolling people who are HIV infected over the age of 35, because anal cancer is extraordinarily rare at younger ages. They get a pap smear, they get high-resolution anoscopy with biopsies. If they have these high-grade lesions, then they're eligible for randomization, and half the people get treatment of the HSIL, whatever their provider thinks is the best, in accordance with the protocol, and then the other group gets close observation with high-resolution anoscopy every 6 months, and for at least 5 years, but probably up to 8 years of follow-up for some patients. And it's enrolling over 5,000 people with high-grade disease, so it's quite an amazing, it will be an amazing achievement. And it's great to say that enrollment is underway, that I think about 10 people have already been randomized, and we have about 5,000 to go. But, so it's going to be an amazing effort, and the sites will be all over the United States at pretty much all the major metropolitan areas. And all our sites will hopefully be coming on board over the next year.
Yeah, this has been an amazing effort. I know that we were talking about this more than 10 years ago in the AMC, and it's nice to see this finally happening, and that the NCI has stepped up with the incredible amount of funding needed to make this happen.
It is incredible support from the NCI, really, for this.
Great, thank you for that. So Dr. Borok, do you want to bring us up to speed on what's happening in Africa with the AMC?
Well, I was interested in yesterday's talk by Dr. Borok from Uganda, who was talking about, he was giving his views about what was needed to build capacity, really, for us to be able to do studies. Every site is different, and the AMC has now got 4 sites that are working and going to be enrolling in studies in Africa. So Zimbabwe is one where I am, Uganda, and there's a site in Johannesburg, and there's a site in Kenya. We're all very different, I think.
Yeah.
And I think there are plans to increase the number of sites, which is really exciting as well. And we see a lot of late presentation of Kaposi Sarcoma, of carcinoma of the cervix, and so these are really important studies for us to be involved in. And it's, there's a lot of capacity building that is going on, and which maybe wouldn't have happened without studies such as the collaborative KS study with the ACTG and the AMC, and the CA cervix study, which is an ACTG study, and there are going to be, we're running a CA cervix study with the AMC, which has also been something new for us and has been very interesting for the site, and I think will be good for training doctors and for building capacity in other ways, and improving lots of aspects of how we manage cancer, chemotherapy administration, pathology improvements. There are a lot of areas where I think this is going to be important.
Well, I think certainly in Africa, the HIV epidemic has resulted in a huge influx of increased capacity, and has this benefited cancer treatment as well?
Absolutely, and I do think that we're starting to see a change in the pattern of our cancers, moving from the AIDS-defining cancers to include some non-AIDS defining. I don't think we're at the point where the US is, but and at least in my country, we're only 10 years into antiretroviral therapy rollout, so the patterns are a little bit behind. But I think it will be interesting to watch.
Terrific. Thank you very much. So, Dr. Mitsuyasu, as chair of the group, what struck you as being presented at CROI that was of interest, and then what other activities?
Well, I think overall, one of the encouraging things was the renewed interest in malignancies in HIV. It is a part of the AIDS epidemic from the very beginning when it was first described, and I think people have kind of forgotten about it to some degree over the years as antiviral therapy has gotten better and survival has improved. But as we heard yesterday at our symposium on AIDS malignancies, it still remains one of the major causes of mortality in HIV-infected individuals around the world. And while we recognize that there are AIDS-defining cancers and non-AIDS-defining cancers, we're seeing an increase in many of these tumors in both categories, despite the fact that we have better treatments. So this, I think, brings up a lot of opportunities, both for kind of understanding why cancers are still quite prevalent, what we can do to try to both reduce the occurrence of these tumors, prevention if you will, as well as improving the treatments for these various malignancies, which is one of the things the AMC focuses on, and to, again, try to encourage physicians, people that care for patients with HIV, to recognize that this is still a major issue and to discuss various aspects of treatment and prevention with their HIV populations. One of the things that we heard this afternoon at a theme discussion in which they focused primarily on non-AIDS defining cancers in various age populations is that it is occurring both in youngsters, in older individuals, as well as the general HIV population, and that lung cancer particularly has become a major issue as people both get older, but even in younger people with HIV. And that anything we can do to kind of discourage smoking, that can encourage taking antiretroviral therapy to improve immunity, to do things that are better for people's health overall, will, I think, in the long run, improve overall health and outcomes in our populations. And that's obviously one of the things that our group, the AIDS Malignancy Consortium, is focused on. We're trying to both reduce the morbidity and mortality from these various tumors, both in the US and around the world. So I think that is kind of the take-home message that I got from this meeting, that people are recognizing that AIDS malignancies is in fact a continued issue in the AIDS epidemic, if you will, and that we need to continue to focus on it even as we go forward with trying to improve treatment for HIV in general.
Yeah, I mean, certainly people living with HIV are aging up and living into an old age they never expected to have. And I think they need to think about cancer prevention and the health, preserving your health by healthy habits, such as quitting smoking and eating well and that sort of thing. So I think you're right. We really have a long ways to go in terms of educating people on how to live with HIV successfully for the long term. Was there anything else any of you wanted to bring up that came to mind as we were talking?
Well, I think not only what Ron had to say about the prevention aspects, but one of the things that we still need to learn a lot about is how best to treat these common cancers that occur in the general population in people who are on antiretroviral therapy. And so that's been one of the focuses of the AMC recently in trying to understand better whether people who are on antiretroviral therapy can tolerate the same kinds of cancer regimens as people who are not on those drugs, and whether there are any drug interactions that people should be aware of in terms of providing effective therapy. I think the other thing that is near and dear to my heart on the international front is the whole idea of trying to develop more pragmatic therapies that are easier to implement in lower resource areas, and that's one of the things that we're trying to explore in a new study for lymphoma that we are opening in the very near future that will be conducted at our African sites.
Terrific, thank you. Anybody else have anything you'd like to add? If not, thank you so much for joining us today. We really appreciate this opportunity to talk with you and hear about what's the advances happening in the world of HIV and malignancies. Thank you very much.
Thank you.